leg. We then think about areas A, area B, area C, and area D of Hackett. And so we're injecting on the ilium itself and then more deeply down into the sacroiliac ligaments with multiple injections into this area on the ilium as well as deep down into the sacroiliac joint area. We then reorient our needle, coming around in a more cranial direction to hit the bottom fibers of this, points C and area D. We then remember our lines of injections along the gluteus, attachments of the gluteus maximus and medius, and we do fanning of those injections, keeping in mind that as we move down the ilium, if our needle is directed in this direction, we're just going to slide off the ilium and not hit anything. So that we have to reorient our needle coming in so it's perpendicular to the bone. If one can imagine in one's mind's eye the direction of the bone and keep the needle perpendicular to it at all times, this is helpful. We mentioned that the line between the top of the trochanter and point D, or the bottom of the PSIS here, is a line right along here, is a safe area to inject. You'll be out of the sciatic nerve in that area, and you can inject on bone all the way above that. We look at the attachments of the sacrospinous and sacrotuberous ligament. We see this huge ligamentous structure which blends the sacrospinous and sacrotuberous ligament together and comes in and blends into the posterior sacroiliac ligament. To inject the sacrospinous and sacrotuberous ligaments and their attachments on the sacrum, we have to push the tissue down quite firmly, come in, and hit the edge of the sacrum. If we miss it, we may be too far over, or we may be sliding over the top of it. So what we can do is feel where the edge we feel it is, and then come straight down with our needle until we hit the edge, and then walk in this direction off until our needle drops off, and then orient our needle onto the side of the sacrum to hit that point. The coccygeal injections are actually very easy to do because most of the time people have very specific tenderness on the coccyx in the areas that they are finding painful to sit on. So you can come in and just hit those little areas, and they're often very tiny areas right on the bump of the coccyx. It's also possible to put people in a knee-chest position and to put your finger in the rectum and do your exam with the finger under the coccyx, pushing up to get better access to the coccyx itself. You can also do a rectal exam and feel the sacrospinous and sacrotuberous ligaments in the rectum and come with your finger on those ligaments directly in until you feel the needle pressure, being careful not to go too far, and injecting into the attachments of those ligaments right onto the sacrum as your finger palpates that area from the rectum. In injecting the lumbosacral area, we can stand to the side of the patient and a bit caudally. We can then carefully palpate the spinous processes, the interspinous areas, and then with our fingers locked over the spinous process, coming directly down onto the spinous process, doing skin sliding or re-entering with our needle into the interspace between the spinous processes in a caudal direction with our needle. Again, the next spinous process all the way down to L5, but being careful not to go into the area between L5 and S1 as the dura mater can protrude into this area, making it easier to do a spinal tap. Our next line of injections are into the facets or the facet area that we can see here. Again, we're not attempting to enter the facet directly, but really the capsular area around it. We know that in most patients, those facets lie in a direct line with the interspace so that if we come a finger breadth off and down into that area, we will be in the area of the facet capsule. We need to be careful not to go too medially. It is possible to hit nerve roots in this area, so we need to take care, if we don't feel the bone, to come back out, redirect our needle a bit, and find the facet area. It's also possible in this area to inject the multifidi that attach to the side of the lamina by holding on to the spinous process and then directing our needle medially directly into a line below our finger and thumb so that we hit the side of the lamina here. We need to be careful in doing this not to direct our needle caudally or cranially so that we might do an inadvertent spinal tap. But it's a very safe injection if we're careful to go directly in underneath our finger that's attached to the spine. In addition, we wish to inject the tips of the transverse processes at L4 and L5. These are the attachments of the iliolumbar ligament, which we can see right here coming up and attaching to the L4 transverse process and the L5 transverse process. The injection is carried out by feeling the edge of the paraspinal muscles and then going in, and this will be about 3 finger breadths off the spine, going in a little bit of a medial direction, keeping in mind that often these are in line with the top of the spinous process, but there's enough anatomical variation that you may or may not hit it with that. Going in as far as you think safe, coming back out, redirecting the needle a little to the south or to the north to try and find that tip of the transverse process. Our next line of injections will be along the iliac crest, and the iliac crest points can come all the way out to the lateral iliac crest, in which case it may be easier to place the patient on their side so that's elevated. Posteriorly, you can easily hit it from this direction, placing your fingers along the ilium and then coming in with the needle directly onto the iliac crest, again fanning your injections all along it in a peppering fashion. In addition, we can push the tissue down and or slide the needle underneath the ilium and feel it slide along the ilium, injecting the bone on the underside of the ilium, going down all the way down into the deep area of the cleft between the sacrum and the ilium, right down in here. And we can see the firm ligament that's part of the interosseous ligament down in this area. We can also reach that point and that area of the deep interosseous ligament by going approximately halfway between the spine and the ilium at the L4-5 level. And with our needle directed in a caudal and lateral direction, sliding into that cleft, getting deep in and again hitting bone. Injections in this area will often cause a warm feeling down the leg or a sensation down the leg. But this is an important area to hit that deep interosseous ligament. We then move on down the spine. We can see the roughness in this model, and that's because ligaments attach in this area. And we hit the areas along the spine itself, area A, area B, area C, and area D. We then drop deeper in to get the posterior sacroiliac ligament fibers, injecting 2 or 3 directions with each needle stick. It's important to stay lateral with our needle aimed laterally and avoid coming in the midline halfway between the spinous processes and the ilium, because we have the openings that can lead directly into nerves here and cause nerve damage, our foramina. Occasionally, you'll find tenderness medially, and if we do these injections, we need to aim directly toward the spines for the medial fibers. Most injectors don't do that as a routine, but it is an injection that's possible as long as you stay out of the midline. We come on down to area C and area D, and we can see how huge these ligaments are in this area, so that we're really coming in an upward direction and peppering that whole area around areas C and D with multiple injections. If we come down on the ilium here, that's fine as well. We also are going to be coming along the back side of the PSIS, a very important area to inject as we come back up. Even if you don't do the gluteal attachments out here, you need to do this back side of the ilium here. The attachments of the sacrospinous and sacrotuberous ligament, the sacrotuberous ligament here originating on the tuberosity, and the sacrospinous ligament under here originating on the spine of the pelvis here, coming up and attaching on the lateral border of the sacrum and blending into the posterior sacroiliac ligaments. This really is a huge mass of ligament, and so injecting all in it is valuable. We feel the edge of the sacrum, realizing that that's often the perceived edge rather than the real edge, since there's a lot of tissue between us and the bone. We push down that tissue as much as we can and come in a lateral direction to medial, trying to find the very edge of the sacrum, which is where those ligaments attach on the sacrum itself. If we can't find it, we can come back up and come in a straight down direction and move medially until we hit the edge of the sacrum. Then, once we found the edge, drop down so that we're catching the fibers along the lateral border of the sacrum. Again, to demonstrate that, we come down until we hit the edge of the sacrum with our needle, and then we come in laterally and hit the lateral border of the sacrum from this direction. This requires a lot of tissue being pushed down out of the way so that the needle can get in and reach that lateral border. To inject the trochanter, it's best to have the patient lying on their side. This elevates the trochanter and makes it easier to find. The trochanter can be surprisingly difficult to find. You feel it, but when you try to inject it, you just slip somewhere where there's nothing. So it's best to try and find the top, the front, and the back, and to carefully palpate all around that area. Frequently, I think people make the diagnosis of trochanteric bursitis by just pressing on the trochanter in one spot and saying that's trochanteric bursitis. I believe that trochanteric bursitis is a vastly overrated diagnosis, and that most of the time this represents ligament pain that involves the front, the back, all down the trochanter and down the femur, a third to halfway down the thigh in the tensor fasciae lata. So once we think that we found the edges of it, then what we do is again carefully palpate all around the trochanter as we go right around it, and marking tender areas, which usually is all around the front, all around the back, and then right down the middle, clear down the femur, again half to a third to halfway down the femur. When we're injecting this area, then, we need to find as close as we can to the top of the trochanter, and we need to come in with our needle and then come back out to the skin level, slide up in again until we drop off the edge of the trochanter. Once we've marked where that is, then it's easier for us to find our orientation and accurately find the edge of the trochanter and inject around the edge and around the front edge, and then down the middle, even with 2 rows, through the middle of the trochanter, and then following the femur down by using skin compression, because the femur is not very wide, right down the femur where the tensor fasciae lata runs right down the side of the femur. This is a convenient position also to do our intra-articular injections. And once we found the top of the trochanter with our needle and done the injections in this area, with the legs slightly elevated at the knee with a pillow between the knees, this elevates the leg like this and makes it easier to enter the joint. We, of course, aseptically clean the area that we're going to inject. We come off, we can find the top of the trochanter and then slide off the top of it and slide our needle down, and we'll be in the hip joint. You can feel it pop in and then feel bone, and an injection in this area of 25% solution is required. The solution should flow freely into this area, and the patient shouldn't have pain, as with all intra-articular injections, when we do the injection. Again, it's very important to remember not just to do 1 or 2 spots on the trochanter, but to carefully, in our usual peppering fashion, pepper the entire trochanter. We talked about the posterior capsule, and we can see here that this is the area where the posterior capsule attaches. We find the edge of the trochanter, the posterior side of the trochanter, come back from it into this depression, and we find that just medial to that, we aim our 3-inch needle down into that depression where people are tender, and we're injecting along the posterior capsule in that area. To inject the trochanter itself, we need to turn the patient on their side, and again we feel all along the back of the trochanter, the top of the trochanter, and the front of the trochanter, as well as down the middle of the trochanter and down the femur. And then our injections should be carefully done all along those areas, covering as much of the trochanter as we can. And injecting then with our fingers locked over the femur, injecting right down the edge of the bone. We're now going to be doing the anterior part of the hip and pelvis area. The first part of this is to orient ourselves anatomically. We need to find the pubic symphysis and follow over the pubic ramus. We know the pubic symphysis in the middle here. Coming down on it from above is an excellent way to orient ourselves on that. We then come across the pubic symphysis and mark the ramus right across. And then we orient ourselves by finding the anterior iliac superior spine right here. And we know that below that and down is the inferior spine right there. The attachments of the rectus femoris come up onto the inferior spine. Sometimes you can feel down directly on it and feel it. Other times it's a bit indistinct, and to inject it you just have to approximate the area, remembering that it's about 1 centimeter over and down from the superior spine. The next orientation that we do is coming across with a line directly in line with the pubic symphysis, and then a line down from the anterior superior spine. It's in where these cross that we're looking at the hip capsule and coming into then the anterior capsular ligaments of the hip. So we'll start our injections in this area by coming down onto the pubic symphysis. Often this is a tender area right at the symphysis, but even more frequently I find that it's tender all across the ramus. In our skeletal model then, we're looking at the hemipelvis here, with the pubic symphysis right here, the center, and the ramus across with the adductors, the longus and brevis, and the pectineus attaching here, and then into the capsular muscles, or the capsular ligaments rather, that come up from the hip itself and attach to the pelvis in this fashion. Again, the superior spine here and the inferior spine here with the attachments of the rectus femoris here, the attachments of the sartorius on the superior spine here. So we're going to be locking the pubic symphysis between our fingers and coming down directly on it with our needle, moving over and marching over as far as we can to get the beginnings of these ligaments in this area. And you really push down quite firmly, and you'll find that people are tender right along that area. And again, this adductors and these ligaments kind of combine to form this tissue along the ramus here. So we walk across as far as we can feel, and I can still feel ramus right there, coming down into that area, and just injecting small amounts of solution all across the pubic symphysis. We then feel the artery, which we can feel right here, and we know from our markings down from the anterior superior spine and in line with this that we want to avoid the artery, and so we come lateral to that and come in this direction toward the midline of the body and so if we orient ourselves on this model, we can see the ASIS here coming straight down in a line here and straight over in a line like this. We meet right here, and so our artery will be running right here, and our needle then will enter and slide in under the artery and coming into the capsular ligaments like so. Again, important to always feel bone and inject on the bone in this area and going underneath the artery and nerve and vein that we know are medial to our needle entry point. The anterior superior spine, if it's tender, and the inferior spine should be injected as well. More often, the inferior spine seems to have tenderness than the superior spine. Another area of injection on the pelvis is down along the pubic bone here, moving down from the pubic ramus onto the attachments of the adductor magnus down in this area. To accomplish this, we have the patient bring their leg up and lay it out and just relax. We then come in and find the pubic symphysis again, and then the tendon of the adductor magnus right here, and then we need to come in fairly deeply, and there we're right on that bone below the pubic symphysis right in here. And in people who do skiing, jobs where they're spreading their legs and lifting, these are often very, very tender areas. And so in addition to injecting along the ramus of the pubes, we need to come into this area right down to the adductor magnus and carefully pushing the tissue in quite firmly and then coming in with our needle, and it won't be a very deep injection into this area.